Hi, my name's Danielle Burney, and I'm a family nurse practitioner student at Franklin University. I'm going to present mental health topics for special populations, including geriatric individuals, pregnant and postpartum women, pediatric patients, patients within the LGBTQ+ community, and immigrant and migrant workers. It is important to screen these patients as these populations have higher rates of mental health disorders and problems, and these are often overlooked. First, let's dive into the geriatric population. By 2030, 1/6 of the population will be 60 or over. That's 1 billion people in 2020 and 1.4 billion people in 2030. We let that sink in a little bit because the population is aging fast, and 14% of adults over the age of 60 suffer from a mental health disorder. Older adults have many risk factors, such as increased social isolation with aging, loneliness that comes with that. Dementia, depression, and anxiety often increases related to decreases in income, isolation, chronic illness, and a reduced sense of purpose. The economic impact is substantial with increased costs from prolonged hospitalization and long-term care facility stays. There are many different screenings that can be used in the geriatric population. The most common include geriatric depression scale, the PHQ-9, which we're very familiar with and we'll see in other populations as well. We can also use a mini mental status exam to determine cognitive status and abilities. Yearly depression screenings can alert the provider to investigate further. Mental health problems are prevalent in this population, making them vital to screen. For assessment, it's important to consider other possibilities such as neurological conditions such as dementia, Alzheimer's, metabolic disorders, infection, and even polypharmacy. If confusion is present, we can consult family members for help on getting an assessment, history, and physical. First-line treatment for older adults for mental illness would be psychotherapy, medication treatment, and/or electroconvulsive therapy. We want to encourage exercise and social engagement as they can benefit from this, but if it's severe, you may have trouble encouraging that. Always depends on the severity and type. We want to assess whether it's chronic, prior to response to treatment, and patient preference. And then you can always combine treatment methods. Psychotherapy is often underutilized, and the medication selection is based on comorbidities, side effects. Overall medication monotherapy is preferred, and then SSRIs are considered first-line treatment, which we'll see later in many different populations as well. In this population, though, we do want to start them at half the dose of a younger adult due to decreased drug clearance. Also important to consider that these might take longer than somebody a little bit younger than them, maybe like 8 to 12 weeks. So we want to keep assessing the effectiveness and give it time to actually take effect. So now we're going to move on to talk about pregnant women and postpartum women, as they are at a greater risk of mental health conditions as well. 10% of pregnant women and 13% of women postpartum experience a mental health disorder, with higher numbers actually in developed countries. This can negatively impact child development and growth. There's an alarming number of women that experience these symptoms so severe that they would actually harm themselves or their baby. So very important to screen these individuals. So it's so important to screen these individuals because hormones are rapidly changing, lives are changing, children are coming home. There's a lot of new things going on, lack of sleep. So we want to be able to distinguish postpartum blues from mild to moderate and even major depressive disorder. New mothers with major depressive disorder can have a large effect on baby and children, so early intervention is extremely important. We can use the common tools like the PHQ-9, and then one we haven't talked about yet is the postpartum, the Edinburgh postnatal depression screening. For the DSM-5 listed criteria for major depressive disorder is that the patient must exhibit 5 symptoms during a 2-week period, although a little controversial in that, in my opinion, because the postpartum period is considered 12 months after giving birth. Treatment options include medication therapy, psychotherapy, or a combination of medication and psychotherapy. The main therapy options include cognitive behavioral therapy and interprofessional therapy. There is a new FDA-approved medication called zuranolone, which is a 14-day course with symptom improvement, hopefully within 3 days. Typically, the choice of medications to be used for like depression and anxiety in pregnancy and postpartum is SSRIs. The first drug choice would be sertraline, as it's safe in pregnancy. You definitely want to be aware if your patient does want to breastfeed, and still may be important to choose a medication that can be used in breastfeeding, even if they don't want to, just in case they change their mind, because you definitely want to use the same treatment choice in pregnancy and in postpartum, and you kind of want to just, the treatment does outweigh the risks here with depression. And then, important in every population to rule out other causes by ordering a TSH, T4, CBC to check for anemia, fatigue infection, vitamin D, B12, and folate deficiencies, and a CMP for electrolyte and liver function, especially prior to starting an SSRI. Now we're going to talk about pediatric mental health. It's definitely undertreated and underdiagnosed. Almost half the children with depressive disorders are not treated. About 16% of children under the age of 6 have significant mental health problems. That's definitely higher than I thought, which is probably one of the reasons that this is overlooked and not treated. Suicide is definitely on the rise and has become the third leading cause of death for children 14 to 18 years of age. So this is why we want to screen this population. Common screenings in the pediatric population are the PHQ-9, which is modified for adolescents. You can also use the mood and feelings questionnaire assessments for these patients. And then just remember that this is not to diagnose, but to screen. The provider still needs a full psychiatric and medical history. Mental status should be assessed, and a physical exam. And again, on these patients, we want to do labs, ruling out thyroid disorder, infection, electrolyte abnormality, checking liver function. And then important add-on here would be a urine toxicology to assess for illicit substance use. DSM-5 criteria for major depressive disorder is 5 symptoms that they list in the same 2-week period, with at least one symptom being depressed mood or loss of interest or pleasure. And then other notable things to assess in these patients would be home stressors with family conflicts, school stressors such as bullying. The treatment plan and the approach to the pediatric patient should include collaboration with the family and the patient. Doesn't matter the age, the patient should still be included. You want to involve specialized care such as a psychiatric or a psychologist. And again, we can use a combination therapy, pharmacotherapy, psychotherapy, or a combination. Really just depends on that severity or duration. We want to know if agitation is present in the patient, are they suicidal or homicidal, and so many factors go into this. Definitely if the patient is moderate to severe, they should have combination therapy. And over the age of 8, we can use SSRIs, particularly fluoxetine. Combination therapy has been proven to be more effective, so depending on the situation. And you might want to get the school involved, especially if there is bullying or other health conditions, just so that they're aware of what's going on with the patient. So now we're going to move on and talk about the LGBTQ plus community, as they're at a higher risk for mental health conditions, and they're actually more than twice as likely to suffer from mental health conditions compared to heterosexual adults, with transgender individuals are 4 times more likely. So we definitely want to keep screening these individuals. They're definitely negatively impacted in the community by discrimination, prejudice, denial of civil and human rights, harassment. They may experience family rejection, leading to higher rates of mental health conditions. They're also more likely to experience substance misuse and experience homelessness. Screening tools for this patient, we can use the PHQ-9 if they're an adult, or the modified if they're adolescent, for mental health conditions and depression, anxiety. We should definitely ask the patient about emotional health, social isolation, self-esteem, anxiety, depression, self-harm, home safety, about their home life, their school life, and bullying, and then if they feel safe within the community. The DSM-5 criteria for specific mental health conditions is the same for adults, and then same for pediatrics within this population. It's just, the risk factors are a little bit different, but not the diagnosis. Treatment can include psychotherapy, pharmacological therapy, or combination therapy, definitely depending on the age of the individual. Goals of treatment would be to achieve remission and restore baseline functioning in the patient. And it's just shared decision making with the patient and really depends on severity. We can use SSRIs or SNRIs. What I'd like to add here is you want to use a lot of collaborative care. Definitely always have a psychiatrist or psychologist depending on severity, but In this case, possibly endocrinology if there's hormone therapy, and then gender affirming supportive care should always be provided too. All right, and last we're going to talk about immigrant and migrant workers. They're also part of this group because they have a higher prevalence of mental health conditions compared to local workers, typically from financial constraints, lack of access to health care, poor living conditions, higher working hours, low job security, and workplace abuse. We're going to use some of the same assessment tools we talked about, the PHQ-9. You definitely want to be aware of any language barriers or cultural differences. Some cultures are not forthcoming to admit symptoms of anxiety, depression, or PTSD due to stigma. They also might not know the specific word in translation, so we definitely want to get a translator, but they definitely might not want to disclose information to fear of legal repercussions or fear of being misunderstood. So definitely getting a translator and making sure that you're providing culturally competent care is important. And the treatment in this population would be the same, definitely either medication, psychotherapy, or a combination. Definitely want to keep ruling out the differentials that we talked about before, and then offer support when you can. Community services, therapy options, if limited income, then definitely offering more community sources with food help, legal support, social services, and then finding somebody that they can communicate with appropriately and understand their culture is very important. And here are my references. Thank you for listening to my presentation on special populations.